By the end of this lecture, you should be able to identify various types of cardiovascular diseases, understand various risk factors of hypertension, and apply measures of prevention and control of hypertension. Cardiovascular diseases include congenital heart and vascular diseases, rheumatic fever, ischemic heart disease, cerebrovascular diseases, and hypertension. Many of these conditions end up in heart failure or cardiovascular failure, which should not be considered a separate cause of death, but a complication of any of the above-mentioned diseases. Let's begin with hypertension. Hypertension or high blood pressure is a long-term medical condition where the blood pressure in the arteries is persistently elevated. High blood pressure usually does not cause symptoms. Long-term high blood pressure is a major risk factor for coronary heart disease, cerebrovascular accidents, renal disease, and other vascular complications which are responsible for more than 50% of mortality. High blood pressure is classified as either primary or essential hypertension or secondary hypertension. In terms of statistics, above 90 to 95% of cases are primary, defined as high blood pressure due to non-specific lifestyle and genetic factors. The remaining 5 to 10% of cases are categorized as secondary high blood pressure or secondary hypertension, defined as high blood pressure due to an identifiable cause such as primary renal disease, some endocrinal disorders, or even secondary to the use of hormonal contraceptive methods. As treatment of hypertension is effective but is lifelong, prevention is a major challenge for public health and preventive medicine. The latest classification of hypertension, according to the 7th report of the Joint National Committee on Prevention, Detection, Evaluation and Treatment of High Blood Pressure, included that normal person has a systolic blood pressure between 90 to 119 millimeter mercury and a diastolic blood pressure between 60 to 79 millimeter mercury, and that pre-hypertension state the systolic blood pressure is between 120 to 139 millimeter mercury and diastolic blood pressure between 80 to 89 millimeter mercury. Stage 1 hypertension has a systolic blood pressure between 140 to 159 millimeter mercury and a diastolic blood pressure between 90 to 99 millimeter mercury. In stage 2, the systolic blood pressure is between 160 to 179 millimeter mercury and the diastolic blood pressure is between 100 to 109 millimeter mercury. As for stage 3, the systolic blood pressure will be more than or equal to 180 millimeter mercury and the diastolic blood pressure will be more than or equal to 110. Prehypertension is a precursor of clinical hypertension and is closely related with the increased incidence of cardiovascular diseases. Patients with prehypertension, which is 120 to 139 systolic blood pressure and 80 to 89 diastolic blood pressure, have an increased risk of cardiovascular morbidity and mortality compared with patients who have normal blood pressure, less than 120 over 80 millimeter mercury. The overall prevalence of prehypertension during 1999 to 2006 was 36% all over the world, which was higher in men than in women. In Egypt, percentage with hypertension has dramatically increased to 39.7% in both sexes, 38.7% in males, and 40.8% in females, as reported by the Ministry of Health and Population in STEPS Survey 2011 to 2012. Prevalence varies between governorates. It is more in urban than rural areas. Risk factors of hypertension include unmodifiable risk factors and modifiable risk factors. Unmodifiable risk factors include age, sex, family history and genetic factors, race, vascular changes and atherosclerosis. Regarding age, blood pressure increases constantly with age. As for sex, blood pressure is higher in males than females until menopause. Then the ratio changes from 2:1 to 1:1 due to the decline of estrogen hormone in females after menopause. Family history and genetic factors play an important role in determining blood pressure. Similarity of blood pressure levels among first-degree relatives as parents, siblings, and offspring is commonly observed. Race also plays an important role. Hypertension is more prevalent in black races than white races in the USA. Vascular changes and atherosclerosis, which starts since childhood as unhealthy dietary habits and genetic factors, interact in hypertension causation. Modifiable risk factors include socioeconomic factors, diet, weight gain and obesity, smoking, alcohol, hyperlipidemia or hypercholesterolemia, psychosocial and cultural factors, and finally, lack of regular physical exercise. Socioeconomic factors as mental, psychological, and social stress are inversely related to blood pressure. Certain stressful occupations favor the development of hypertension, such as drivers, physicians, nurses, and teachers. Diet is another modifiable risk factor of hypertension. High salt and sodium intake in food is a risk factor. A major source of sodium is soft soda drinks. High saturated fatty acids intake increases the risk of hypertension. The major sources of saturated fatty acids are fats of animal origin, fats in the meat, butter, and whole milk. Weight gain and obesity. The body mass index is positively and strongly correlated with blood pressure. The blood pressure increases with the increase in weight and vice versa. Smoking also is positively correlated with blood pressure. Smokers have a relatively higher blood pressure than non-smokers. Regarding alcohol intake, there is a strong positive correlation between alcohol and blood pressure levels at high levels of intake, more than 20 glasses per day. As for hyperlipidemia or hypercholesterolemia, it is a major modifiable risk factor of hypertension. Increased low-density lipoproteins and decreased high-density lipoproteins are positively correlated with blood pressure. Regarding psychosocial and cultural factors, stress and cultural changes are positively correlated with blood pressure. Cultural changes as migration, for example, rural to urban or across countries, may change dietary habits and lead to weight gain. Lack of regular physical exercise is another modifiable risk factor. Prevention of hypertension include primary prevention as well as secondary prevention. Primary prevention includes population strategy and high-risk approach. Population strategy includes health education about reduction of the risk of developing high blood pressure in the population as a whole. As regard healthy diet through decreasing salt and salty food intake, decreasing soft drink consumption, the use of polyunsaturated fats as vegetable oils, rather than saturated fats, as fats of animal origin. Maintaining normal body weight, promoting regular physical exercise, for example, at least half an hour, 3 to 5 times weekly. And finally, smoking cessation. This should be done in line with the high-risk approach, which includes identification of individuals with modifiable factors and trying to modify such factors among them. On the other hand, secondary prevention of hypertension includes identification of individuals with high blood pressure, lifestyle changes, strategy of treatment of prehypertension, enhancement of patient compliance or adherence to treatment, and finally screening of hypertension in high-risk children and adolescents. Regarding identification of individuals with high blood pressure who are at increased risk of complications, this is performed through screening and case-finding programs and offering them early and effective intervention. Lifestyle changes include dietary approaches as the DASH diet, which is the dietary approach to stop hypertension. It is recommended by physicians for people with hypertension or prehypertension. DASH dietary pattern is rich in potassium from fruits and vegetables and calcium from skimmed dairy products, low in total unsaturated fats, and contains limited amounts of meats and sweets, salt and sodium intake reduction, and regular physical activity. Strategy for treatment of prehypertension is also important. Individuals with prehypertension should adopt a healthy lifestyle in order to lower blood pressure and prevent progression to hypertension, which will reduce target organ damage and cardiovascular events. The pharmacological treatments could be used on condition that lifestyle modification trial fails to reduce the blood pressure to 130/80 mm mercury or less, according to the guidelines for prehypertension without diabetes or chronic kidney disease. Enhancement of patient compliance or adherence to treatment. The treatment of high blood pressure is lifelong, and this develops the problem of patient compliance, which is defined as the extent to which patient behavior in terms of taking medication, following diets, or executing other lifestyle changes coincides with clinical prescription. The non-compliance rate to antihypertensive drugs in Egypt ranges from 25 to 50%. The compliance rates can be improved through education directed to patients, families, through patient support and reminding of drug intake, and to internal medicine physicians through educating them how to reduce the non-compliance of patients to drug regimens and to the community. Finally, screening for hypertension in high-risk children and adolescents who have positive family history, smokers and obese should also be performed.